afternoon. Welcome to a conversation on vaccine equity, building trust among communities of color. I am Kiana Thomason, President and CEO of Health Forward Foundation. Thank you for joining us for this vital conversation. Vaccines have been a powerful public health tool since the 1940s, changing levels of disease and death and improving life expectancy around the world. Currently, our health systems are working in overdrive to ensure communities are vaccinated for the seasonal flu and against childhood illness amidst a global pandemic and rapid development of COVID-19 vaccines. There are many complicated questions regarding COVID-19 vaccines. Amongst those is ensuring that research, development, distribution, outreach, and communication strategies engage people of color as we bear a heavy, disproportionate burden with coronavirus mortality rates as high as 2 to 3 times our white counterparts. To engage communities of color effectively, health systems will need to overcome a range of barriers, many of which are rooted in historic abuse and mistreatment by the medical system and ongoing implicit bias in healthcare. It's equally important to understand that communities of color are experts in our own lived experience and know the solutions that are effective in building trust in our communities. Initially, there may be insufficient COVID-19 vaccines to meet demand. It's anticipated that vaccines will be distributed in phases, and some people will be vaccinated before others. The natural question is, who should have access to the vaccines first? The National Academy of Medicine drafted a framework for equitable allocation that outlines principles for COVID-19 vaccination distribution. It prioritizes distribution of vaccines in phases, with priority populations designated to highest risk individuals. There are, however, legal and ethical challenges still being understood that prohibit explicit prioritization of people of color. Hence, questions abound regarding how vaccine equity will be achieved. Today, we will hear from leading voices in public health, healthcare, philanthropy, and grassroots human service organizations. They will share their expertise on vaccine research, distribution, and trust building in Black and Brown communities. With that, I'd like to introduce our esteemed panel. Erica Andrade, Chief Program Officer of El Centro. Erica leads implementation of strategies related to community education, health, economic empowerment, advocacy, and engagement to meet El Centro's mission of strengthening communities and improving the lives of Latinos and others through educational, social, and economic opportunities. Dr. Rex Archer is Director of Health for the Kansas City, Missouri Health Department. Dr. Archer has served on and led numerous national committees involving public health and is responsible for safeguarding the public health of nearly 500,000 Kansas Cityans and a population of nearly 1 million people. Dr. Daphne Bascom is Vice President of Population Health at St. Luke's Health System in Kansas City. Dr. Bascom's work has been dedicated to improving the health of communities around her and making sure that these communities are connected to the best resources and technologies available. Dr. Alonzo Plow is Chief Science Officer and Vice President of Research, Evaluation, and Learning at the Robert Wood Johnson Foundation. Dr. Plow is responsible for aligning all the foundation's work with best evidence from research and practice and incorporating program evaluations into organizational learning. Dr. Plow has been a national leader in public health practice for over 25 years. And most importantly, he's a Kansas City native, and we are so glad to welcome him back home virtually. Also joining us, maybe a little late, is Dr. Barbara Pahoud, she's here. Dr. Barbara Pahoud is Director of Infectious Disease and Research at Children's Mercy Hospital, Kansas City. Dr. Pahoud is an internationally recognized expert in the field of vaccine safety, vaccine hesitancy, and the impact of clinical trials. I want to welcome all of our panelists. Thank you for being with us today.
Thank you for having me.
Thank you. So let's jump in, and I think it's best to start with the basics. Dr. Pahoud, while many of us are focused on new vaccines, in fact, vaccines have been in wide use for over 80 years. What's the basic science behind vaccines and how they protect us from disease?
The basic idea is that we're trying to give vaccines to patients to avoid them being exposed to the actual disease and having to suffer through the disease itself. So when we give them a vaccine, we're basically training the immune system to recognize that disease. That way they will not have to suffer the consequences of the disease itself. The immune system will have a minor training of that disease, and you will have some reactions potentially to the vaccine. Like when you get the flu vaccine or the measles, mumps, rubella vaccine, you may feel some achiness, you may have some soreness on your arm. That's your immune system working, creating antibodies to fight that disease. And that is preferred to you being actually exposed to, for example, influenza and having to be hospitalized with the disease. So you have a minor exposure to the disease, which helps your immune system prepare. And then when you're exposed in real life to that disease, your immune system's ready and you avoid the major complications.
Thank you for that level set. I think it's important to start with the basics. So just yesterday, the FDA approved remdesivir, an antiviral for hospital treatment of COVID-19. However, there are many other vaccines still under development. Dr. Plout, what do we know about those that are in development and what's still uncertain for us?
Well, it's complicated. It's really good to get that background on vaccines in general, because if there's anything that's characterized an improvement in population health over the last nearly 100 years, it's been the effectiveness of vaccine, particularly childhood vaccinations. But with COVID-19, we are chasing a fast-moving pandemic with a fast-tracked production of a number of different approaches to vaccine development. At least 5 or so in the US now at different stages. And I think it might be good for the audience just to know generally that these stages are essentially federally approved designs to make sure that the promise of the vaccine, which was just articulated, is in fact achieved with good safety so that it can be distributed more broadly and nets positively. And that takes some time, and people are seeing a lot of things about phase 2, phase 3 trials. So they're moving along. There are slightly different approaches in each of those, but I think right now it's good that they move along at the usual pace. I think that the usual pace allows us to pause those vaccine trials, which many of your listeners may have seen, which is a good thing. That says they are paused whenever there is something that comes up with one of the people in the panel, may not be related to the vaccine at all, but as an abundance of caution, you check everything. So that's what's happening now, moving through that progress, which is a scientifically defined mechanism and not a politically defined mechanism.
And just to add something to that, if you don't mind, this is something that has happened forever in clinical trials. It's just now being displayed in the news media for the public, but this is nothing new for us investigators that have always suffered through haltings while we investigate side effects, et cetera. I just wanted to clarify that for the public.
Absolutely. This is good science in practice. Good science in practice. Not you should be concerned if it was moving up at a pace where things were not adjusted in the course of what we're learning. So but that's kind of where we are now, and maybe if later we can go into more detail.
Sure, we can certainly do that. Thank you for that. So pauses are good. We'll revisit the speed in just a little bit. Unfortunately, many people of color have experienced discrimination in and even been victimized by our health system. And of course, we still have implicit bias that's embedded in our systems. This experience can make people of color reluctant to trust the healthcare system. How might we build trust in communities of color, specifically related to this vaccine? Erica, I'm going to start with you.
Sure. I think this is something that we're seeing actually even happening right now with people having a lot of fear and questions surrounding the vaccines, and there's information already out about studies, and they're offering money for to join the studies. And so it's definitely a question that needs to be asked, because I mean, just earlier this month, we all heard the breaking story of some immigrant women in detention, in ICE detention, that are having surgical procedures done to them and they don't even know what's happening. As shocking as that is, that's actually more common in everyday kind of health experience for women that, for anybody, for immigrants and for people that where English is not the primary language. For example, working at El Centro and in nonprofit work, we sometimes host things like mobile mammograms and mobile pap smears, when we're trying to get, the community to do the right thing, get checked, get tested. It was shocking to me to see how many women were coming in for a pap smear that turned out didn't have a uterus because it had already been removed and they were not aware. So this is not something that is, happening somewhere away from us. And so to me, the way you build trust is that we have to build a healthcare system that is inclusive, and then the way that they treat their clients, patients, is equitable from the beginning to the end. You can't have a healthcare system that refuses services to individuals because they don't have insurance or because they don't have proper documentation, and then expect them to trust you when you want them to come and get vaccinated.
Erica, those are very gripping experiences of women of color that you've shared. What's the role in language in those experiences?
I think it all really does come down to language. If there's not an appropriate person that can do proper interpreting, not relying on family members, not relying on children, and not just medical interpreting, but it's about culturally appropriate medical interpreting. We have to take these things at a lower level of understanding to explain to people what's happening to them, making sure that you're asking them questions. Did you understand? Does that make any sense? And not rushing through things, because it is going to take a little longer for some of these populations to really conceptualize and grasp all of these kind of concepts, because they're so foreign from the countries that they're coming from. We also have to kind of put it in that concept. It's hard for me, when your doctor's telling you all of these things and you're trying to pretend you understand what you're saying and you're shaking your head. Imagine if language is also an issue, how that can compound the situation.
Well, and we also have a real cultural challenge in this country, because if you don't address the elephant in the room for folks that are Black in regards to Tuskegee and what happened there, you may not understand where that distrust is. As tragic as the 300 people that were denied treatment, the breaking of trust with government was huge. But what's happening is that people aren't understanding that was a denial of effective treatment. So if people decide not to participate with safe vaccines, they're actually Tuskegeeing themselves by denying themselves of an effective treatment. And sometimes if you reframe that for folks that way, they can start to understand, what's going on. And with all of our vaccines, they're always safer than the disease that we are trying to develop the vaccine for. Can you imagine, though, with Ebola as an example, if we have a 70-80% mortality rate from Ebola, that then does have to be fast-tracked, because even if the vaccine was to have a 1% mortality rate compared to the risk of the other for high exposures, you've got a balance of safety. So, but none of our vaccines that have ever moved through phase 3 trials and be approved in this country have had, any kind of a real mortality rate. It's been extremely, extremely rare.
Thank you for that. And you said something particularly important, and that was Tuskegeeing themselves. I want to come back to that a little bit later when we talk about the importance of people of color in research. Dr. Bascom, what's your take on how best to engage communities of color? You have vast expertise in population health and community health in many different settings and communities.
Kiana, I want to just go back to something Erica said, because I think what we can distill that down to is we have to authentically engage our communities of color, which means that we need to we need to listen. We can't always talk at people. We need to listen and understand what those fears and concerns are so that we can respond to them appropriately. But then we also need to apply resources in venues where our communities actually receive information that they trust and they feel is safe. And that may be the physician's office, it may be the church, it could be the barbershop. We need to have conversations with our community, not one-sided. They have to be, we listen, they listen, and we understand the concerns so that we can meet people where they are. But we need to apply resources to ensure that there's competency and literacy and for those that are already in the community to help us deliver those messages. Otherwise, people are filtering things on social media, they're filtering things on television, and I'll be honest with you, sometimes it's hard for me to know what's the truth. So translating that down, back to Erica's point, not only English, Spanish, Chinese, we're a multicultural community, but making sure it's culturally appropriate and delivered by those that the community has trust in.
Thank you for that. So what I heard was bi-directional listening, trust-based engagement, and culturally resonant engagement.
And transparent.
And transparency.
There has to be,
yeah.
We can't set up expectations that this is going to be 100% effective. We can't set up expectations that we know all of the complications. So there also, in my mind, has to be a level of transparency.
I appreciate that. Thank you. Dr. Plow, so from a research perspective, people of color are underrepresented in clinical trials across the board, including vaccination or vaccine clinical trials. What are the strategies being employed across the country to engage people of color in COVID-19 trials? And what are the risks and challenges if we have insufficient numbers of people of color participating in these trials?
Well, let me bridge to the previous discussion because the context is one of legitimate historical mistrust and lack of connectedness to the healthcare system. If you've been marginalized from the healthcare system and don't have a usual source of care, you are alienated from that system, and you're not going to have built up the trust that a vaccine that's been developed rapidly like this is something that you're going to take. So part of the issue around volunteering for a trial and essentially assuming some risk for the greater good requires a whole lot of trust that there will be a return on investment to your community based upon that individual commitment, and that might not historically be there. And you see that in differentials in organ donor rates in communities of color. So it's a more general thing, but it is a problem not of the willingness to help in our community. It is a legacy of the same distrust that we talked about before. I think it is aided by recognizing that, and I can speak to what I've seen going on in New Jersey, because we are next door to the Johnson & Johnson trial, and I've been working with that a bit. Very extensive efforts to do recruitment of people of color into the trials, very aggressively, using trusted voices in the community. And then, as also was said, and we'll come back to it later, there's vaccine development, that's a science thing. There is vaccination in the community, that's a social, political, economic trust thing. We have to work on both of those. The trial is a science piece, and it needs to have the proper representation of the population to receive the vaccine. But the real challenge is the other piece. And as Rex knows, those of us who have run vaccination implementation programs in big population areas, I led the H1N1 vaccine response in the 11 million person LA County, highly diverse. The health happens when the trust happens, and you're able to develop the right kind of messaging, trust, to actually get the shot in the arm. And that's a very important thing. So both, I think we should be talking about engagement, both on the trial side, but also engagement on the trust building community interface side.
And what that says to me, Dr. Plow, as a healthcare practitioner, I'm now in philanthropy, but been a healthcare practitioner in the past, is we need to start engaging and building trust before we're trying to vaccinate someone for something new. Like,
yes,
backed way up. Got it. Dr. Bahoud, you have international experience in vaccine hesitancy. Your thoughts here?
Well, and it's not just about the vaccine hesitancy piece. Actually, I'm going to talk about the more practical piece of it.
Okay.
For us, of course, we have to have trust. But even if you have trust, if you don't go to the participants, they're not going to come to you. There's a very practical reality about clinical trial enrollment is usually carried out in what we call the ivory tower. the big medical center, where most of our participants are white. And for example, in Kansas City, if we were to enroll all our participants of our vaccine clinical trials at KU Med, we would be excluding a large Hispanic and African American population. For us to go to them is what matters. Of course, there has to be trust, but even if there's trust, if you don't give them access to the trial, they're not going to be able to participate. So what we're doing is we are hiring mobile units. We are going to where the participants are. We are parking ourselves outside of Swope Clinic, Health Partnership, and trying to do outreach into other places like Wichita, Tabernacle Church, Dole's food companies where these populations are at, because if we go to them, we make it easier for them to participate in the studies. We can't expect them to carry the whole weight. We have to make it hard on us to go to them. It is harder and more expensive to do clinical trials that way. But if we don't do that, we're going to keep maintaining the 95% white enrollment population in clinical trials.
Thank you for that community-centric approach. I think our audience would like to hear more about that, specifically about where that's happening in Kansas City. So perhaps as a follow-up, Dr. Pahud, you can share that information with us, and Health Forward will send it out. Sure. Thank you very much. Let's pivot back to the speed in which these vaccines are being developed. That makes a lot of people nervous, whether they're Black, brown, or white, right? So what can you all tell us about the speed and its relativity to efficacy and safety?
So I can chip in here if you don't mind. Number one, the way that I try to explain this to people that don't usually do clinical trials is, if you want to make a lasagna and you want to make it from scratch, and your grandma tells you she wants it ready in 5 minutes, it doesn't matter how much power your grandma has. You have to do what you have to do, and it has to cook for the amount that it has to cook, and there's no way you can speed it up. So number one, I want to reassure people that there is no shortcut to doing the science. You have to immunize people. You have to go through phase 1, 2, and 3 clinical trials. And after you do the phase 3 clinical trials, you have to have enough time to evaluate for safety and efficacy. It doesn't matter who tells us how fast we need to go. You cannot make up that data. The only way to skip the process and make it faster is do what the Chinese and the Russians have done, which is start immunizing people and skip the phase 3 clinical trials. So you can just give the vaccine to the public and not know what happens. So speaking about what Alonso was saying earlier, if there is an adverse reaction in a clinical trial, we know about it, we halt, we investigate. In China and in Russia, there may be those adverse events happening, and guess what? Nobody's watching, because these people are not in a clinical trial. They're just being given the vaccine. So this is my way to reassure the public that even if it's frustrating to them to think that the US is taking longer, why does Russia have a vaccine and the Chinese? Well, because they're not paying attention to those side effects. They're not doing the work that we're doing to make sure vaccines are safe. So the fact that we have halts, the fact that you're reading on the news that there was a death in the Brazil clinical trial should be reassuring for you all to know we are watching and we're slowing down to make the science work.
Yeah, and that is so important, and I would add to that, because it is obvious that not just science is driving this, and I can understand the administration's sense of urgency, and I'm a Star Trek fan myself, but Operation Warp Speed doesn't. Yeah, I know, that's great, way to go. But an unfortunate framing given what you just said. But I think your audience should really feel comfortable, because the manufacturers themselves sort of pushed back against any sense of urgency that wasn't safe, all made a pledge to follow out the phases as were just outlined. And I think that the science is driving this on the vaccine development side. I just think that's very important for the audience to know. And it is far better to go through phase 3 and have that information than something rushed out. But also, as a public, with Rex and others on here, as a public health practitioner, the other really important thing is the masking, the social distance, because that's going to have to happen for quite some time, because it isn't clear, as you just laid out in the introduction, when there will be sufficient supply for people. So I'm just hoping that COVID fatigue doesn't set in so much that we on a population health level can't keep up those things that are truly preventive, the hand washing, the mask wearing, the social distancing, not doing some of our favorite things.
Thank you for that. Let's stick a pin in the supply question because I think that's important given what we experienced early on with PPE and other shortages. So we'll stick a pin in that. I want to circle back to the trust building. I think we need to give a little bit more to our audience relative to the mechanics of that. What does that look like? What are the implications for the undocumented population? That's a whole nother layer that needs to be considered. Erica, can you lead with that? And then Dr. Bascom, Dr. Pahoud, interested in your thoughts as well. Oh, you're on mute, Erica.
Sorry. That does add a whole nother layer of complexity to the issue because right off the bat, a lot of individuals who do happen to be undocumented are not going to think that they can even participate in any of the trials or be eligible for vaccines because that's also something that's come up. And if they are, is it going to be expensive? Is it going to be available in safety net clinics or in bigger kind of healthcare institutions like hospitals, things like that, which then also, because of their built-in policies, already are known to discriminate against them if they're uninsurable, which, you know, it just layers onto that fear and not wanting to trust and it's not even that they wouldn't want to get it, because I'm sure there's a lot of families that want it. They know it's important. There's, you know, they're essential workers, so they're out there. They understand that they need to protect themselves. But actually believing that they're not going to be eligible or they won't be able to receive it is going to be something that's going to be really hard to fight against. That kind of fear of coming out into open and exposing themselves.
Do you think there will be fear around deportation? I put my name on a list, I get vaccinated. Will I get deported? How do we address that in our communities?
That's exactly. Anytime that you ask an individual who's trying to live in the shadows and not give too much information, they're going to have to provide something. And that's already always, you know, we saw it with census work. Something as, you know, that used to be something as safe as a census, all of a sudden now it's like, nope, they're going to put me on a list. They're going to know everything about us. And so, so it's going to be really, really difficult. It's going to take working between hospital systems, clinic systems, and community agencies, people that have that connection and that trust built in with a community, working together to really push that message that it's not that won't happen. But also, honestly, for ourselves, like for organizations like Central, for us to believe that information really won't ever be used again. We have to have that, because I'm not going to put my reputation, El Salvador won't put their reputation on the line if we don't have 100% trust ourselves. And this goes for lots of our smaller grassroots organizations. We're very protective of our community.
Absolutely.
There's a level of complexity even on top of that, whether it's undocumented or homeless. This isn't a single dose vaccine. So when you start to look at populations that may be undocumented or may not have a stable home, how are we going to make sure that they actually, whether it's 2 doses or 3 doses, that they come back and we can contact them to get that second dose so that they can obtain the full immunity from the vaccination? And, you know, the whole supply chain, the whole tracking and distribution, that's another level of operationalization from the community perspective that a lot of our populations are going to be challenged with. Sorry, Erica, it's just that really,
you're absolutely right.
We need to think about now.
Yeah. Thank you for that. Much to consider. A good takeaway that we need to equip and educate first our grassroots leaders to get them comfortable. So there needs to be some strategies around how to do that well so that they can in turn be partners in educating the individuals in our communities. Let's pivot a bit to the national guidance. The National Academy of Science Framework for Equitable Allocation of Vaccines highlights ethical principles such as maximizing benefit and mitigating health inequities, as well as procedural principles such as fairness and transparency. Yet we understand that explicitly prioritizing people of color based only on their race or ethnicity may be unlawful and unethical. So how might we see this national guidance play out in our local communities? They say all healthcare is local, right? So what are the nuances that we might see here in Kansas City in light of this national guidance?
Well, the reality is that if you know where you've got the most disease, then you try to move to that area to also do the vaccination. And then you're not doing it by color, even though it turns out that it is by color often in those geographical areas, but you're doing it based on what you actually know and where the prevalence of the disease is. And then we can get past those kind of challenges.
Dr. Plow.
Yeah, Rex is exactly right. And I think the report talked, one way to get around it is that since we know the risk factors, the social contextual risk factors that lead to the extra risks that people of color have, CDC has something called the Social Vulnerability Index. You can map it, and then you can prioritize based on a mapping of those factors that show kind of marginalization that make people more susceptible to COVID. That's the way to do that, and I think the kernels of that are in the NAM recommendations.
Mm-hmm. Thank you, Dr. Bahoud. Anything to add here?
Well, I had something to add about the prior comment about trying to make people might be afraid of participating because of ICE, things of that sort. And I just wanted to add again the practical piece with clinical trials. We usually give participants compensation for their time and for being part of a clinical trial. And one of the hurdles we've seen, for example, with Latinx community, because they're undocumented, is they may not want to participate because we're not going to be able to compensate them, since usually you need a social security number to do this. So I just wanted to share that part of what we're doing in these clinical trials to be more inclusive is we have figured out a way around this loophole, and now we are basically taking the taxes of that money and being able to give participants those funds without asking for a social security number. And this is our way of trying to show them that we are not going to try to give their names out or follow them ICE or tag them with social security numbers. So again, it's just little things like this that build the trust and ensure that they can participate in clinical trials.
Thank you. So the trial that you are co-leading will use the monetary element as a recruitment factor.
It's all clinical trials usually have reimbursement. The problem is in the past, Latinx communities that are undocumented have not been able to, because one of the requirements is the social security number. And if you don't have one right away, that knocks you out. So what we said is you do not need to have a social security number to participate. You'll still be able to be compensated.
So that needs to be amplified, that messaging. Thank you for that. All right, let's talk a little about the supply issue. So we are all acutely aware that during the pandemic, our communities here in Kansas City and across the nation experience unequal access to personal protective equipment and testing supplies. So when the COVID-19 vaccines first become available, initial supplies might be insufficient to meet demand. What supply chain issues do we anticipate? And how could those supply chain issues influence equitable access? Dr. Plow or Dr. Archer?
Well, we saw this with H1N1, where the issue was not so much on the science side of of getting the vaccine. It was all around distribution, and it was all around the dependency we have of pharmaceutical companies to manufacture at scale and collaboratively. And those of you who remember the H1N1 rollout, there were many delays and many promises those of us in public health made that delivery was right around the corner, and it wasn't. The children's dosage lagged, a modality lagged. So I think the honest thing to say to the audience and ourselves is it will be quite a challenge, and there will be delays, and there will be some uncertainty in the rollout, even with the best of intent to do that, which really means that these ethical and humanitarian principles and these equity-based principles just need to be at the forefront to help guide us under that uncertainty. But from managing H1N1 rollout in LA County, there will just be logistical delays that are going to require, I think, that they get better with exquisite local partnerships that actually know neighborhoods, people, and can help with that supply chain activity. And as others on the call can say, the ability to get deeply and involve other partners with something that requires cold storage has always been a problem.
Yeah, I'm going to look at this at a little higher, very difficult challenge that we have that has been unprecedented with this virus than we've had with any other communicable disease. And that's when the scientists are ignored, the ethics is ignored, and decisions are coming out of the White House that then come down and force states on how it's going to be distributed, et cetera. If they follow whatever is adjusted, and it may adjust as we learn what happens with these clinical trials, if a vaccine doesn't work as well for the most vulnerable population, you may actually prioritize those that are around them first to wall off and keep the disease from getting to that person because they don't develop a very strong immune response. And we're not, it's going to take a while before we fully understand how long immunity lasts and who develops the best immunity. So whatever guidance is being discussed now may change, but the question is public health even going to be part of that decision, or is it going to happen in the governor's office and they're going to tell the National Guard or somebody else, this is how it's going to be distributed at the local level? We just don't know what's going to happen with that. I mean, I tell folks all the time, if this gets expedited beyond what I think is a fair clinical trial process, with the exception of every other vaccine that I think is supportive, I may actually say, no, don't take this. We don't know that it's safe. But if it's proven to be safe, and if I'm in the high-risk category that benefits from it, I'll be first in line. But if I'm not, H1N1, I wasn't in the first tier. So even though I wanted the vaccine and had flu shot every year since I was 17, I had to hold off until I was in the tier that was being allowed to be given the shot. So, but we just don't know how this is going to come down right now, and that's a big concern.
Dr. Archer, can we look to prior experiences with other vaccines? How has it worked between local public health department and our state government, our health departments? How has it gone in the past? Is there any indication of how it might go going forward?
Well, that's my problem, is that I don't know that past has much precedent with the current, because every other major outbreak, the CDC, took the lead. They weren't being muzzled. They would keep the Department of Health and Human Services and the Cabinet and the White House informed. They then worked with state and large metro health departments to figure out what needs to be done, who then advise their governors on what needs to be done. That's all been torn apart, where the White House is directly dealing with the governors, particularly the governors in the red states, and is bypassing those formulations and procedures. And sometimes the state health department is the last one almost to find out what's actually being said or told or going on in this process. And so, yeah, it's very uncertain, and that really concerns me right now, that we do not know what our role is going to be in regards to the vaccine distribution.
So while we don't know what the role of the local public health department will be, we do know enough about the science to begin to translate that to the communities that we serve, and to begin to convene and talk about this, to begin to build trust in preparation for distribution. Is that fair?
Yeah, but what we don't know is some priority going to be developed at some high level that comes down that does or doesn't take into account what the National Academy recommends. Those are the variables that we don't really know, because there's been so much inconsistency coming out of the White House and the gagging of CDC and various recommendations. So I, in full transparency, I think I have to just admit, I don't know how this is going to work. I know how we're going to push and what we want to do to be able to get the vaccine to the people that will benefit the most and are at highest risk, but that doesn't mean we'll be allowed to do that.
Understood. And thank you for that transparency. I think that's key to trust building. So while the pandemic is on everyone's mind these days, we know that routine vaccines are more important than ever, and it's flu season. Children are falling behind on their immunizations. People are still fearful of going into their doctor's office or their healthcare clinic. What can you all share with us relative to talking to parents and assuaging fears around getting access to care for routine vaccinations? Dr. Bascom, let's start with you.
So this is a great question. And I would say for definitely want to hear what Dr. Pahud has to say, but for our children and for our adults. Our health system, I want to say back in March, early April, our clinical leaders actually started reaching out to families and letting them know that our doors are still open, that it's still very important for your children to be immunized, because we don't want to create an unintended set of consequences for children that don't receive their immunizations. There are catch-up schedules, and you can always catch children up that maybe were delayed in receiving a dose. But we've been trying to undertake strategies to make sure that the kids can come into clinic safely, they can receive their vaccinations on time, and that we're reaching out to your trusted healthcare provider and encouraging you to come in. But we definitely saw data from our Vaccines for Children program at both a local and national level that showed that the number of doses being distributed had declined significantly. So we need to continue to proactively reach out, both for ensuring that our children are vaccinated, but also that those adults, especially those who may be at risk, whether for the flu, pneumonia, have underlying diseases such as COPD, that they're also feeling that it's safe for them to come in and receive their routine vaccination and generally.
So what I jump in here and say is, if you have ever seen the movie Contagion, if you have not watched it, there's 5 minutes of that movie I want everybody to watch where Kate Winslet explains what the reproductive rate of a disease is. In that case, she's talking about an influenza-like virus. And the reproductive rate, because she does a better job than I will, but the reproductive rate of the virus is basically if the entire population is not, has never seen that disease, like with COVID. If the entire world is susceptible to that disease, and that disease goes out into the community, how many people will get infected if you are, if one human being is out and about, how many people will contract it? The reproductive rate of COVID is about 2 to 3, 2 to 4, somewhere along those lines. We're still finding that out, and it varies population to population because this reproductive rate number varies depending on whether you live in Montana and you barely see a soul, or you live in China and you are stuck with 10 other people in the same apartment. I hope that makes sense to everyone. Well, what I want to say is the reproductive rate of measles is about 15. So let me explain that in simple terms. If one person has COVID and they go out into the community, they may infect 2 to 3 people. That's why the reproductive rate is 2 to 3. If one person has measles and they go out into a community of susceptible people, they'll infect 15. So the importance of maintaining immunization coverage in the setting of this pandemic cannot be stressed enough. We have about 150 influenza pediatric deaths a year, and we've had about the same number with COVID. So we don't want to drop the immunization rates of all these other diseases that have taken us so long to control just because we're afraid of this other disease, COVID. This is what the world looks like when we don't have a vaccine. Imagine what will happen if we have measles, polio, HIV, everything else back. So please, I urge you, no matter what fear we have about COVID, I am more afraid of bringing all those other diseases that has taken us years to control.
And most of us never lived in a world where we didn't have the vaccine, so we don't know what that would be like.
Yes.
Well, some of us stood in line at the YMCA in Kansas City in the 50s to get the Salk
Sugar cube.
vaccine. You know, because a couple of generations, I had friends that had polio. You know, but we're 2 or 3 generations removed from the immediacy of what happened when we didn't have preventable vaccines. Just to echo what Barbara said, we don't want COVID to have a multiplier effect of making it even harder for us to keep our children and all populations appropriately vaccinated.
So underscoring, go ahead, Dr. Archer.
Well, I was just going to say that for anybody listening, the healthcare settings take infection control extremely seriously.
Yeah.
We're not seeing COVID, we're not seeing any of these diseases spreading in healthcare settings. So going in to get vaccinated is safe. Not going in is dangerous. And so I really, really want to put that into perspective. Now, early on with any new infectious disease, yes, we have to kind of, well, are we doing infection control perfectly? Do we have everything we need to stop the spread? But we're not seeing the spread of this infection in healthcare settings.
So, Dr. Archer, are we seeing from a local data perspective that routine vaccinations have dropped? Are you seeing that in the data? And Dr. Bascom, are you seeing that from a utilization perspective?
Yeah, we're seeing that. I mean, part of it is that one of the ways that we get folks cleaned up, and what I mean by that is they should be getting their routine vaccinations, through those early months and years of life. Sometimes those don't happen as well as they should, but the schools catch that. And so with in-classroom and requirements, we're able to try to at least catch folks up at that point. So usually when we have some of these outbreaks, it's because of the kids that haven't gotten them before we get to the school age. With flu shots, as an example, we basically would be better off as a country if we just mandated it for everybody that didn't have an appropriate medical exemption and just did it. But that's not the case. We can't produce that kind of vaccine right now. There's probably enough vaccine to be able to treat or immunize those that want the vaccine right now. But I've often thought, but this is kind of anti-transparency, is to say, no, we don't have enough, so you better get it quick. Because then more people will actually get vaccinated, because it's almost like Americans have to think of, if there's a shortage and I've got to go out to get it, they'll go get it. If you tell them that we've got plenty and you can get it anytime you want, then they don't act as fast. But so I'm kidding a little bit on that, but the real challenge is, as a nation, we haven't made the commitment to produce enough vaccine to be able to vaccinate everybody, even if they didn't want to have it. And I actually think we should pay people to be vaccinated the same way that we pay people for clinical trials. We ought to just do it. It's in the public good.
So do we have a shortage of the flu vaccine right now, locally or nationally?
We're having some challenges, and I think, as an example, I think Children's Mercy has usually orders like 3 different groups. They get it for their staff to be sure that they're protecting and not exposing their patients. They then get it for their patients, and then they get it for their community clinics. And I believe that 3rd order has been delayed right now, so it has not come in. So there is some challenge in the delivery of the vaccine. Most years, in fact, it's very few times do we have a peak in influenza before the middle of December. So if we can still get the vaccine and get it into most people before Thanksgiving, we should be in pretty good shape. But none of these groups are really committing, unless you've got some more recent data, Doctor, from Children's Mercy on their supply.
I get Oh, sorry. I could say from a community standpoint that this has been actually a question we've been getting a lot of calls about. And we find that this year we're not getting as many offers to do free community events for vaccines. And when they do, they're very limited. So we had one that we hosted at our academy and they only had 50, which 50 was barely enough for the parents at the academy. So we really couldn't open it up to the community. So it is something that people are asking. I mean, if you have insurance, it's great. You call your insurance, you get it. It's not an issue. But for all those individuals out there that don't have insurance, or homeless population or immigrant population, flu vaccines are not easily available and they're not free, or there's not a lot of free options, and that's what they need.
I don't want to leave the older population out of this as well, because there is a national shortage of the senior dose on flu. And again, that's a double vulnerability with COVID. So,
Sure.
yeah.
Thank you. So what is being done nationally with respect to flu? Are there nuances in how the senior population is approached relative to distribution of the vaccine? And what's the nuance for COVID?
Well, as the data shows, I mean, the senior population, and particularly senior populations institutionalized in nursing home settings, have been one of the hardest hit groups. And then also with differential impact on elders of color. So I think that is recognized nationally, and it's varying state by state and city by city on how aggressive they are being on the outreach and trying to address that. I know we're doing a lot of work to try to promote that kind of outreach. Some of the things that we fund, but there appear to be more supply challenges nationally than I remember in the past. At least what I'm seeing on the national picture.
Mm-hmm. It should be noted that the National Academy of Sciences framework for equitable allocation does prioritize older adults, specifically those living in congregate living spaces, like senior living facilities and nursing homes. There's also state plans out for equitable allocation of vaccines. All states had to have their plans submitted to the CDC by October 16th. Missouri and Kansas does have a plan. You can log on to the Missouri and Kansas Department of Health websites to access what those plans are. Regarding philanthropy, and specifically health philanthropy's role in vaccination education and outreach. Dr. Plow, you lead at Robert Wood Johnson Foundation, the leading international public health foundation. Of course, Health Forward has a role locally. What should we be focused on?
Well, first, we should be focused on partnerships between local and national philanthropy, which is a lot of the way that a national philanthropy works. But we have been focused on. I mean, for us, COVID helped us to understand that our general focus on health equity was the right focus, and so we redoubled our efforts. Both to address some inequity around COVID and some of the supporting some of the activity of community trust building, community power building that we've talked about today. But we actually see. I mean, this is the novel virus of the day. There are other disproportionate health risks that will happen down the line. We are trying to use this COVID awareness opportunity to highlight what you have to do to change those underlying conditions that have put particularly communities of color at more risk to this than is fair and just. And then working with a variety of other philanthropic partners for the role that we can be as a catalyst in this, and what we have to do to provide better connectivity around the nation so we have better data. Disaggregated data, our current racial data is not sufficiently disaggregated to understand exactly what's going on in the very diverse populations when we say communities of color that we're talking about. So we're really pushing on that as well, because we've seen where a lot of this breaks down in COVID. And as a national foundation, we're working with other philanthropy, CDC, and at the moment. And then as the other thing is, as you know, Kiana, we can sometimes say and voice things in philanthropy that the government can't at the moment. So we are using our voice in support of science, in support of the equity principles. And I think that's a very important role philanthropy plays, as well as our orientation to community engagement in the work that we do.
Thank you. Very, very helpful. Dr. Archer, Erica, any suggestions for health philanthropy?
Yeah, so I look at part of it is we are continuing to graduate from high school a hugely disproportionate number of folks that are science illiterate. Most of our elected officials at the state and federal level don't have science backgrounds and don't understand the science principles. They don't understand the difference between a virus and a bacterium, let alone these kinds of discussions. And so, we have to get a population that understands this at a whole different level so that we can be transparent with them, but you can't in a media soundbite take somebody through a few hours of immunology. You just can't do it. So I think that's one piece. The second piece is we don't seem to have any problem with spending 100 times the budget on our Department of Defense than we do on our Department of Biodefense, which is the CDC. And we're not right now setting up systems by which we can ensure that there is vaccine production, and that if for some reason there's leftover vaccine, that those pharmaceutical companies don't take losses from the extra vaccine. We should be ensuring levels of vaccine production, because if we have something come along and we don't have that capacity, we can't turn on a dime. Right now with these trials, no, I don't think we should speed the trials up, but those that are starting to be promising, to start paying those companies to produce that vaccine and pay them if it has to be thrown away. But pay them for starting to produce it now, as opposed to waiting until we get final approval or something. And they shouldn't have to be taking the risk for a population benefit.
Mm-hmm.
I think also one of the recommendations I would say for philanthropic organizations would be that they, yes, invest in the health structures and the health systems, but they need to do it in a way where they either kind of highly encourage or also invest in the community organizations, and partnerships would be better than anything, more than anything, because you really are going to need those community partners, the ones that are working with communities, grassroots, to kind of help out the health systems, to get the information out there, to get the health literacy out there, and to get the community to trust enough in the vaccines or in the treatments that they're going to actually use them. So just investing dollars into the health systems to produce or distribute, that's great. But unless the community is getting the same information, it's not going to be as helpful.
I just want to say the biggest thing we've been doing is on that point, Erica, and I would encourage people to go to our website, increasing community power and capacity to be able to direct and engage the information that's meaningful and have the capacity to work with communities around health affirming activities is probably the biggest thing that we're doing programmatically at the foundation. And I would encourage people to look on the website on this connection that we are making between that kind of community level power and capacity building, which we think connects directly to improve capabilities for health and well-being.
I love that so much. So much, just very quickly, so much power building is talked around policy and community grassroots mobilization, which I think is great. So there needs to be grassroots power building around public health, is what I'm hearing you say, Dr. Plow. Very helpful. Dr. Archer.
Yeah, I mean, RWJ, because of their size and leadership, the Culture of Health Prize that we moved for and got here in Kansas City in 2015 laid out a lot of good things for us to be working on and doing together. Public health accreditation, to where state, local, tribal, territorial, and even now Army military bases and a foreign nation is pursuing accreditation status to improve their capacity. And we have a bill in the Senate right now on Public Health Infrastructure Saves Lives Act that can help rebuild our public health infrastructure so that we can work more effectively with communities to do this work. So, yeah, there are multiple issues. We don't have any health reporters left in the Kansas City metro area. So finding some way to partner with RWJ, I've been planting this seed, Alonzo, but we need funding in at least the 50 largest media markets to have health support, because all these reporters get a health story and they don't know how to work it up. They don't have the science background to cover it. And I ended up spending half an hour in an interview for a 10-second spot because I'm trying to educate the reporter on the health background that they don't have. So there are a lot of things we could be doing differently. And I think, the offices of health equity and racial issues that the Health Forward Foundation is pursuing right now are those kinds of things that can make a difference long term.
Thank you.
We're very supportive of that. I mean, on the website, this public understanding of science, citizen science, campaigns against disinformation, all of those are so critical. And, we are working on that. And go to the website because there are actually funding opportunities in those areas. I knew I'd get a pitch from you, Rex.
Yeah. I'll go to the website and I'll call you directly, Dr. Plow. Thank you. Okay, so takeaways for philanthropy is partnerships, both with health systems and with grassroots organizations. We need to assist in messaging and amplifying the citizen science components. Health Forward has a partnership with KCUR for health reporting, but there are other opportunities that we are exploring with our ethnic media outlets as well, and rural media outlets, as well as public health advocacy for infrastructure and payment and increasing investment. We need to pivot to audience questions. So the first one coming in: what do you say to people who ask about acquiring natural immunity to COVID-19? Dr. Prahood, I think this is a good one for you.
Yes, so the problem we have is, as you know, this virus is relatively new. We still don't know what natural immunity means for COVID. We know that some people have been reinfected. I believe that everybody's going to be able to be reinfected. We just need to see how long it takes for people to have that capacity. So I think we're going to have waning immunity. What that means is you get the disease, you're immune for a while, but then slowly your antibodies start to fall down and you're susceptible to the disease again. Similar to what we see with influenza, for example, or with meningococcal disease. We need to keep boosting people against these diseases because there's waning immunity. The same thing with pertussis. That's why we need to continue to immunize people. We moved from a very good vaccine, the whole cell vaccine, to the acellular vaccine, a very good vaccine that produced long-lasting immunity, but it was very reactogenic, to a vaccine that is less reactogenic but not as good. I think we're going to see those issues with the current COVID vaccine. Some vaccines are going to be very reactogenic, like we're seeing the Moderna vaccine, and people may not tolerate that. They may be afraid of the fact that the vaccine is so reactogenic, meaning you get it and you don't feel well for a day or two, you have fever, you're achy, and people are scared about that. But some that may mean longer lasting immunity. And other vaccines are going to be less reactogenic. You only feel a little chills, but you don't really have a fever, but maybe the immunity going faster. All those questions remain to be answered, both with natural disease and with the different formulations of vaccines that we have.
Thank you. Very helpful. I know a lot of people are concerned when they get the vaccine and they start feeling sick. They say, I'm never getting that again. It made me feel sick. So, be a concern, is that right?
So if somebody gets the influenza vaccine and they say, I felt so sick after getting the flu vaccine, I don't want to get it again. I want to remind people that if this was the influenza virus, what you're getting with the influenza vaccine is this tiny little piece. So if you're getting that sick with this piece, imagine how you're going to feel if you get infected with this whole thing. So I'd rather you feel a little bit sick with this than to get the full-blown disease and get hospitalized or potentially die from it. So I understand that they don't want to feel that, but I would rather they feel that than die from the disease.
Yeah, very effective use of an impromptu prompt with your napkin. Thank you. I like that. Dr. Plow.
Yeah, just to pick up on that point, the audience, everybody's hearing a lot of not great information under the term herd immunity, which also goes to this question. Better to think about it as community immunity, and that's actually related to a high percentage of people being vaccinated, not a lot of people being infected with the disease and dying your way. So I want to take this opportunity so people understand that the path right now before vaccine to protection is not ignoring preventive activities and large numbers of people getting diseases, or it's been proposed, let young people get diseases. That isn't an approach to population health.
Thank you. I'm going to pivot to the second question from the audience. Is there or will there be public access to the data and results of the COVID vaccine trial so we can see demographics and underlying conditions that were tested? The question is on the screen in case you need to look at it again.
Yes, and most of the results of clinical trials get published, they get peer reviewed, and it's also widely available on clinicaltrials.gov. So absolutely that data is available. One of my major arguments always with the anti-vaxxers that I hang out with is that they say all this stuff is secret, and I just tell them, you just haven't looked in the right places. I'm happy to show you where the data is, but yes, absolutely, the data will be available.
Thank you. Third question from the audience. Gonna wait till they post it. A pediatrician said she has witnessed high acceptance of vaccines among communities of color when it comes to vaccinating children. However, there is growing concern that communities of color will be highly resistant to a COVID vaccine. What's the difference? Why is that?
Well, again, because COVID vaccine is new, untested, and if we launch it into the public, it'll be under an emergency use authorization. And there's never been as much coverage on a vaccine clinical trial and the launching of a vaccine and the warp speed as there has been with this vaccine. So let's just give people some credit. Rightly so, people are worried because we're seeing a political debate on the news that is using science as a tool. So I understand where their concerns come from, and it's our job to help them understand, again, the science behind launching a vaccine.
And I would like to commend the pediatrician because obviously she's been listening, she or he, in regards to developing trust with the communities that they're vaccinating. And so that trust will go a long way, that once the data is out there, you'll be able to talk with your communities and help move through that resistance.
I agree. I think that this has a lot to do with the trust factor. Everything that we're hearing about COVID and the vaccine and how it's so politicized, it automatically sparks that fear in people. And of course, just with everything politically that's been happening to communities of color, of course, it's going to be even more intense in those.
Yeah, I agree. I think when you have the legacy of mistrust from the Tuskegee experiment and so many others, and we have the political polarization, Operation Warp Speed attached to that political polarization, it's a recipe for mistrust. Dr. Plow, anything to add there?
Oh, you said it all. I mean, with all the natural scientific uncertainty that is in a trial under daily media scrutiny and the most partisan political context any of us have ever seen, it doesn't, it complicates what would just on the science and public health side be a complicated enough activity. And you said it all.
Thank you. Our final audience question. What can you tell us about the COVID vaccine approved for children? Dr. Prahood, this is probably best for you.
What COVID vaccine approved for children? Where are you living? I want to go to your planet.
Not yet.
Well, number one, there was an article in USA Today where you will see a lot of us pediatricians argue back and forth about the need for a pediatric vaccine. Some of my colleagues, which I respect enormously, believe that we need to slow down that process and wait for adult trials to show safety before we include children. I respectfully disagree. I think we can start including children in pediatric clinical trials early on, carefully, to have data, because my concern is that when the vaccine becomes available through emergency use authorization, every parent is going to want to get their kids vaccinated. Well, not everyone's, but those that want to are going to want to have the vaccine available, and we're going to have not enough data. So we have to be getting this data in parallel in all populations that are at risk. And I know that a lot of people are saying this disease has primarily affected adults, which is true. But again, if I remind you, there's over 100 deaths a year from influenza, and look at the push that we do every year to immunize children against influenza. We've had over 100 deaths from COVID children too. So I don't see why we need to wait just because proportionately it affects children less. And in addition, I can tell you that a lot of schools are not open right now because adults are afraid of being around the little children, which we call Petri dishes. So if there's a vaccine that protects the children and makes them less susceptible to carry this disease, it'll give comfort to the adults to go back. And the faster we can get kids back to school, the faster adults can get back to work, the faster we can get the world back to normal.
Very well said. Thank you.
That's mine.
So I want to get ready to land this plane, and I think it's important to hear your final and most salient word on this issue of vaccine equity and building trust in communities of color. I'm going to start with Erica.
So final words. I think final words, I think you said it earlier when you said it's about collaboration. It's about working together. I can kind of throw in, I'm looking at a comment somebody asked about using minority or, media in this. And it really does have to start being second nature. It can't be seen as an other or an extra step that hospital systems or clinics have to do. It has to be seen as what you have to do. What you have to do is you have to engage with the community. What you have to do is you make sure that the information is out in every single language. What you have to do is that you have to make sure that you're partnering with the organizations that are working with those communities. It just has to be second nature. It can't be an extra.
Thank you. Dr. Archer.
In real estate, it's location, location, location. In this, it's relationship, relationships, relationships. Are we listening? Are we communicating? Are we making sure that we're having those conversations and admitting when we don't know something, admitting when we thought we knew something and it's changed? That's what's happening with this virus. I mean, we now have at least one case where somebody got the virus a second time and died the second time. So we're still learning with this, but we're in this together, and we've got to be in it with our community together.
Thank you. Dr. Pahoud.
I think what Rex just mentioned is very important, communication, but listening. So my grandma used to say, we have 2 years and 1 month for a reason. We're supposed to listen twice as much as we talk. So understanding their fears and their concerns, Tuskegee, we talked about that, but you don't have to go that far back. Erica mentioned how at the border, people are getting procedures without their knowledge. That's happening right now. So how would you trust a scientist who wants to give you a vaccine and you don't know what that vaccine is going to do? What if it sterilizes you? What if it does something to you that you're unaware of? So us listening to what the concerns of the people are, but then also responding and making these clinical trials available to them so that we can have representation and we can inform them about the safety of the product in their community, African American, Latino, children. That's the more important thing. And then once we overcome that barrier, making the vaccine accessible to all these populations.
Thank you so much. And thank you for your leadership here locally on the clinical trial. Dr. Plow.
Well, great comments already. On the trust and engagement issues, this is a pandemic in an ongoing context of an endemic influence of structural racism. And we can't engage with communities just around the pandemic. We have to engage with communities around the persistent conditions that make the unfair outcomes happen. And when people don't recognize that the pre-existing conditions that put you at risk for COVID are also part of that structural marginality, I think legitimate community engagement is understanding the social, economic, and political context that causes this disproportionate impact. And we're not just in it for the vaccine, but we're in it for the longer run to understand how to deal with those conditions. That's authentic two-way communication.
I love it. Thank you for referencing the structural racism components and the underlying issues of socioeconomic oppression and disadvantage. Dr. Bascom.
Kiana, first, I want to thank you so much for inviting all of us to have this conversation today. This is very important. Words matter. I probably close my comments by echoing all of what all of my colleagues have said, emphasizing the need to be transparent. But then I also need to put a plug into, we have to bolster our primary care, bolster our public health, and bolster our community health. If we have not learned anything out of 2020, it's that the three legs of the stool all have to be strong enough so that the stool doesn't topple over. And right now, we're not just teetering, we've toppled. And we need to double down and make sure that our infrastructure for our healthcare system is strong, but also from a philanthropic perspective, that we can invest in mitigating the social risks and helping address the structural inequalities. Otherwise, we're going to have the next pandemic and we're going to be having the same conversation.
Thank you, Dr. Bascom. Health Forward will certainly heed that call on advocacy for reinvestment and public health, both here locally to achieve parity as well as at the state level. There's also an opportunity around power building in communities for the citizen science and the public health infrastructure advocacy. So thank you all for that. We'd like to thank our panelists who've shared such valuable perspectives today. Our experts did reassure us that the vaccine development going on now is based in science, not politics. They reminded us that as we navigate through vaccine development, that's faster than ever before. It's understandable that there is fear, there's legitimate mistrust. So we are encouraged to hear about ways to reach people who are often left out using bidirectional, culturally appropriate and resonant messaging delivered by trusted partners in the communities and going out to meet people where they live and work, as Dr. Fahoud said. Of course, uncertainty will persist in the coming months, and we need to be guided by principles that advance fairness and transparency and equity. Perhaps the most important lesson isn't limited to the circumstances of this pandemic. Rather, it's the need to build a foundation of trust before a pandemic occurs, so that well before the next crisis emerges, we are prepared to work together to engage all people and give everyone an equitable access to vaccines and care. I thank you for your time. Thank you again to our panelists. Everyone, make it a great day. Be well.
Take care.